You know, globally, liver cancer is it's a really significant health challenge. We're talking hundreds of thousands of new cases every year, and it tragically takes just a massive toll on lives. But here's something that might surprise you. While it might seem, relatively rare in places like the United States or Northern Europe, it's actually the second leading cause of cancer-related deaths worldwide. Welcome back to the Deep Dive. Today, we're really cutting through the noise to explore liver cancer. We'll look at its different forms, what drives its development, how it's diagnosed, and the whole array of cutting-edge treatments available now. Our mission really is to dig into this, to differentiate between cancers that actually start in the liver and those that spread there and understand the unique challenges of each one.
Exactly. Our aim is to give you a much clearer picture, highlighting the absolutely critical role of, well, early detection where possible and comprehensive care. We'll try to cut through the complexity and deliver those vital insights drawn, directly from the latest research and clinical understanding.
So if you're looking for a concise, kind of impactful overview without all the usual information overload, you are definitely in the right place. Okay, let's unpack this. Let's maybe start by understanding primary liver tumors. These are the cancers that actually originate in the liver itself. And it's important to note that actually relatively few cancers truly begin in the liver. When they do, though, hepatocellular carcinoma, or HCC, is by far the most common type. It accounts for a massive 75% of all liver cancers.
Yeah, that's the main one.
Now, this brings us back to that really striking global statistic. Well, HCC is responsible for, I think you said, over 500,000 cases diagnosed worldwide each year and is the second leading cause of cancer-related mortality globally.
That's right.
It's quite rare in the United States and Northern Europe. There we see fewer than, 6 cases per 100,000 people?
Something like that, yeah. Very low comparatively.
And beyond HCC, there are a few other much rarer forms, like fibrolamellar carcinoma, angiosarcoma, others. But HCC is really the focus, given its prevalence. A major challenge with HCC, though, is that it's often non-resectable, meaning it's difficult or impossible to surgically remove it.
Right.
Largely due to its rapid growth, its tendency to
Okay.
spread, and just the challenge of detecting it early enough.
And what's truly critical here, especially when you look at that global disparity, is understanding the key risk factors that contribute to HCC. We see a very strong connection to chronic liver disease, particularly long-term infections with hepatitis B HBV and hepatitis C HCV,
Yeah.
also cirrhosis, which is that severe scarring of the liver.
Okay.
These conditions are, well, they're rampant in parts of the world where HCC is most prevalent, and prevention efforts often focus right there.
Makes sense.
Exposure to specific chemical toxins, things like vinyl chloride and arsenic, has also been implicated.
Well,
And maybe less directly, cigarette smoking is a known risk factor, especially when it's combined with, say, heavy alcohol consumption.
right.
And here's a really fascinating detail, an environmental factor that plays a huge role in certain regions. Aflatoxin.
Alpha-toxin.
Yeah, it's a toxin produced by a fungus, Aspergillus flavus. It can be a significant risk factor for HCC, especially in areas like Asia and Africa where HCC is endemic.
Wow. How does that work?
Well, this toxic mold can contaminate foods like ground nuts, grains, that sort of thing, particularly when they're stored unrefrigerated in tropical or subtropical climates. It acts as a co-carcinogen with hepatitis B, so it significantly increases the risk if you're exposed to both the virus and the toxin.
So it's like a double hit.
Exactly. It's a powerful example of how, environmental factors can combine with the viral infections to drive disease.
That's a crucial distinction, really highlights those global health challenges. So we've talked about cancers starting in the liver, but you mentioned something intriguing earlier about tumors that spread to the liver. Can we explore that challenge?
Absolutely. And this statistic, it fundamentally redefines how many people might think about liver cancer. Tumors that spread to the liver from other primary sites, especially from the digestive system, breast, lung, they are found in the liver 2.5 times more frequently than tumors that actually originate in the liver itself.
1.5 times. Wow.
Yeah. So when we talk about liver cancer, often we're actually talking about cancer that started somewhere else and just traveled there. Metastases.
That's a staggering insight. It means for many people, liver involvement isn't the start, but maybe a grim sign of a more widespread disease. How do these malignant cells typically get to the liver?
Well, they typically travel through the bloodstream via the portal system. That's sort of a major highway carrying blood from the digestive organs directly to the liver.
Okay.
They can also travel through lymphatic channels or sometimes just by direct extension from an abdominal tumor that's nearby growing into it.
And why the liver? Is it just a convenient stop?
It's more than convenient. The liver is kind of an ideal place for these malignant cells to thrive. It has this unique environment, a vast, rich blood supply, highly metabolic. It essentially acts like a welcoming home for growing cancer cells.
Ah, I see.
And this also leads to a real diagnostic challenge. Often, the very first evidence of cancer in an abdominal organ is actually the appearance of liver metastases. Without extensive investigation or sometimes even an exploratory surgery or, an autopsy, the original primary tumor might never even be identified.
Mhm.
It really underscores the liver's role as a kind of, a crossroads in the body for this sort of thing.
Okay, so understanding how liver cancer actually manifests itself and how it's diagnosed is obviously critical. Given those potentially subtle early signs, what are the initial clues doctors might look for?
Initially, patients might experience something like a continuous dull ache, often in the right upper part of the abdomen or maybe the epigastrium, that's the area just below your breastbone, or sometimes even in the back. Other sort of general symptoms include unexplained weight loss, maybe a loss of strength, loss of appetite, anemia, things like that. And then on physical examination, if the liver feels enlarged and kind of irregular when the doctor palpates it, that's another potential clue.
Now, you might expect things like jaundice or ascites fluid buildup to be early signs, but that's often not the case, is it?
That's correct. Jaundice, the yellowing of the skin and eyes, that usually only occurs if larger bile ducts get obstructed by the malignant nodules.
Right.
And similarly, ascites, that fluid buildup in the abdomen, typically only develops if tumor nodules obstruct the portal veins or if tumor tissue actually seeds itself in the peritoneal cavity.
So their absence doesn't rule it out early on.
Not at all.
So, okay, once there's a suspicion, what's the typical pathway for getting a diagnosis?
Well, the diagnostic process involves a really comprehensive assessment. It combines those clinical signs and symptoms we mentioned, a thorough history and physical exam, and then a range of laboratory tests and imaging studies. When we look at blood tests, we're really looking for key markers that tell us how the liver is functioning, if it's damaged.
Like what specifically?
For example, increased serum levels of bilirubin or alkaline phosphatase can indicate liver cell damage or maybe problems with bile flow. We also check general blood counts, other metabolic markers, just to get a full picture of what's going on.
Got it.
Now, when it comes to specific key diagnostic markers, alpha-fetoprotein or AFP, that's a significant one. It's elevated in, say, 80% to 90% of HCC patients, often to levels greater than 200 nanograms per milliliter.
Okay, 80 to 90%, that's high.
It is. However, it's important to note that smaller tumors, maybe those under 5 centimeters, they might have normal or only minimally elevated AFP levels. So it's not foolproof, especially early on. Another marker, carcinoembryonic antigen, CEA, that can be elevated with advanced digestive tract cancer. And here's a crucial insight. Using these two markers together, AFP and CEA, is incredibly useful in distinguishing between metastatic liver disease cancer that spread to the liver and primary liver cancer, HCC.
Ah, okay. Because the pattern can hint at where it started.
Precisely. It gives you a clue whether it likely originated in the liver or perhaps came from the digestive tract or elsewhere.
That's really useful. What about imaging? How do doctors actually see what's happening inside the liver?
Imaging studies are absolutely fundamental. We use a wide array, including standard X-rays, liver scans, CT scans, ultrasound studies, and MRI, which gives very detailed images. Arteriography, which involves injecting dye into the blood vessels, gives us a detailed map of the liver's blood supply. That's crucial for planning surgery, for instance. Laparoscopy, a minimally invasive procedure using a small camera, allows for direct visualization of the liver surface. And PET scans are particularly useful for evaluating metastatic tumors in the liver.
So, lots of tools there. Now, what about biopsy? Getting a tissue sample?
Yeah, confirmation of a tumor's histology through biopsy is common practice in many cancers, but there's an important nuance here with liver cancer. There are small but real risks associated with needle biopsy. Things like tumor seeding, where the needle track can potentially spread cancer cells. That happens in about 0.5% to 2% of cases.
Oh, wow.
Yeah, and there's also risk of hemorrhage, bleeding, and even false negative results where you miss the tumor.
Mm.
Because of these risks, actually, many major transplant centers prefer to rely on the characteristic appearance on high-quality imaging or maybe a confirmed diagnosis by frozen section right at the time of surgery rather than doing a preoperative needle biopsy.
Okay, so they weigh those risks.
They do, and unfortunately, another reality is that by the time a primary liver tumor is diagnosed, it may have already spread or metastasized, most commonly to the lung, but also potentially to regional lymph nodes, the adrenals, bone, kidneys, even the heart, pancreas, or stomach.
That truly underscores the challenge and the complexity of diagnosis. So, moving on from diagnosis, what does all this mean when it actually comes to treatment?
Well, it means treatment is often complicated, especially by underlying conditions like cirrhosis, which, as we mentioned, is common and can significantly limit surgical options. And while radiation and chemotherapy are vital tools, they frequently serve more of a palliative role, especially in advanced cases. The focus there is often on improving comfort and quality of life rather than aiming for a cure.
So what does this sort of medical management look like? Are there many different approaches being used?
Yes, absolutely. There's a growing arsenal of medical management strategies. Let's talk about radiation therapy first. Historically, standard external beam radiation had limitations because normal liver tissue is actually highly sensitive to radiation damage.
Right.
However, we've developed more effective, more targeted delivery methods. This includes something called transarterial chemoembolization, or TACE. Yeah. With TACE, a lipiodol-ethanol mixture, sometimes carrying drug-eluting beads, is injected directly into the specific artery that's feeding the tumor. This delivers the chemotherapy right to the cancer cells, while minimizing systemic whole-body effects. There's also percutaneous placement of high-intensity radioactive sources directly into the tumor for interstitial radiation.
Oh, very targeted.
Very targeted. Now, while these approaches can definitely reduce tumor size, their long-term effect on overall survival is, well, it's still being determined in many cases.
Okay. What about chemotherapy? You mentioned systemic often has poor outcomes.
That's true for traditional systemic chemo and advanced HCC. However, targeted molecular therapies have brought really significant advancements. Sorafenib, for example, is approved as the standard systemic treatment for advanced HCC, but specifically in patients who still have relatively stable liver function, what we call child class A.
Got it.
And for patients who eventually stop responding to sorafenib, another drug called regorafenib may be used. For metastatic liver lesions, so cancer that's spread to the liver, systemic chemotherapy is still a mainstay. And the embolization of tumor vessels combined with chemotherapy has shown some promising results there too.
Any other chemo delivery methods?
Yes, there's also an implantable pump method. This can deliver a high concentration of chemotherapy directly to the liver via the hepatic artery. This is mostly used for metastatic disease, and it has shown a, let's say, moderate response rate.
Sounds like a lot of innovation is happening just to deliver treatments directly where they're needed most, trying to avoid side effects.
Exactly. Precision is key.
What about managing symptoms? Like if a tumor is blocking the bile ducts, that sounds painful and dangerous.
It is. And that's where percutaneous biliary drainage becomes crucial. Its purpose is essentially to bypass those obstructed bile ducts caused by tumors. This is often for patients who can't have surgery or are considered poor surgical risks. A catheter is inserted, usually under fluoroscopy or ultrasound guidance, to reestablish bile drainage out of the liver.
And the benefits.
Immediate relief, often. It relieves the pressure and pain from the bile buildup, and importantly, it decreases that severe itching pruribus and the jaundice. It significantly improves patient comfort, quality of life, and sometimes can even extend survival.
Are there risks with that procedure?
Yes, like any invasive procedure, there are potential complications. Things like infection, sepsis, bile leakage around the catheter, bleeding, and always the risk of the duct reobstructing over time. Careful management is needed.
Okay. Beyond these, are there other non-surgical ways doctors are attacking these tumors directly?
Absolutely. There are several local ablative therapies. For instance, laser hyperthermia uses focused heat to cause tumor necrosis, essentially, cooking the cancer cells while trying to spare the surrounding normal tissue. Radiofrequency thermal ablation, or RFA, is another very common one. It's probably the most frequently used local ablative therapy right now.
How does RFA work?
A needle-like electrode is inserted into the tumor, and it emits radiofrequency energy, which generates heat, causing coagulation necrosis. The cells basically cook and die. A tumor up to about 5 centimeters can often be destroyed in a single session with RFA. Local pain or some minor bleeding are common side effects, but serious complications are relatively rare.
Interesting. Any others?
Yeah, immunotherapy is a really active area of investigation. The idea is to harness the patient's own immune system. This might involve giving lymphocytes with anti-tumor reactivity or specific antibody drugs. It has shown some tumor regression in certain metastatic cases where standard treatments failed. There's also transcatheter arterial embolization, or TACE, slightly different from TACE. This just blocks the arterial blood flow to small tumors, basically starving them of oxygen and nutrients, causing ischemia and necrosis.
Okay.
And finally, for multiple small lesions, sometimes ultrasound-guided alcohol injection is used. Injecting pure alcohol directly into the tumors promotes dehydration and necrosis of the cancer cells.
Wow, quite a range of non-surgical tools then.
It's a broad and constantly evolving field, definitely.
So with all those medical and non-surgical approaches available, when is actual surgery, like cutting the tumor out, considered an option?
Surgical resection, cutting it out, is considered the treatment of choice when the HCC is confined to a single lobe of the liver, and importantly, the remaining liver function is deemed adequate for the patient to recover well.
And for metastases, cancer that spread to the liver.
For metastases, resection is only really possible if the original primary cancer site, say, in the colon, can be completely excised and the liver metastasis is truly limited, usually to one or maybe a couple of spots that can also be safely removed, which, as we discussed, is unfortunately rare.
Right. Now, what's fascinating here, I think, is the liver's remarkable ability to regenerate. I've heard stories of surgeons removing huge sections of it.
That's absolutely right. The liver has an incredible regenerative capacity. Surgeons can actually remove up to 90% of a healthy liver, and it can grow back.
90%.
Yeah. However, the presence of underlying cirrhosis, that scarring we talked about, does limit this regenerative ability quite significantly. And increasingly, laparoscopic or minimally invasive liver resection for malignant tumors is being performed, which can mean less pain and faster recovery for suitable patients.
And staging is important here.
Oh, definitely. Detailed tumor staging before surgery is crucial because it helps predict the likelihood of achieving a surgical cure. The preoperative assessment is also extensive. It covers nutritional status, fluid balance, general physical condition, plus all those imaging studies and blood tests to really assess the liver's function and reserve.
What's the most common type of surgery?
The most common surgical procedure for excising a liver tumor is a lobectomy, which is the removal of an entire lobe of the liver, right or left. The incisions used vary depending on which lobe is being removed. Sometimes techniques like hypothermia are used to allow longer periods of restricted blood flow during complex resections.
And what about that local ablation you mentioned? Can that be done surgically too?
Yes. For patients who aren't candidates for a full resection or maybe liver transplantation, local ablation can be used to destroy the HCC. This can be done chemically, like with ethanol injection, or physically, most commonly using radiofrequency ablation, RFA, or sometimes microwave coagulation. These can be performed percutaneously under imaging guidance, or sometimes during an open or laparoscopic surgery.
Okay. Is there anything done after surgery to prevent recurrence?
Yes, particularly for HCC that was related to underlying hepatitis B or C infection. Sometimes immunotherapy with interferon is used after surgical resection to try and help prevent the cancer from coming back.
That's incredible about the regeneration. But for some people, when surgical removal isn't enough or possible, liver transplantation offers another path. You hear about that sometimes offering really good patient outcomes, right?
Yes, liver transplantation has indeed shown significant promise, especially for patients with small, early-stage liver cancers that haven't spread.
But there are strict rules for who gets one.
Very strict. Candidates with liver cancer must meet stringent selection criteria, often referred to as the Milan criteria. Generally, this means having a single tumor measuring less than 5 centimeters, or maybe 3 or fewer separate lesions, with none of them being over 3 centimeters in size, and no evidence of spread outside the liver.
Why so strict?
This highly selective approach is crucial because it has led to dramatically decreased recurrence rates of the primary liver malignancy after the transplant. The 4-year survival rates for well-selected HCC patients undergoing transplant are now approximately 85%. That's remarkably similar to the survival rates seen in patients who get transplanted for non-cancerous liver disorders.
That's amazing progress.
It really is. While transplantation has shown clear benefits for these small, single lesions, its widespread use is significantly limited by the ongoing shortage of donor organs.
Right, the waiting lists.
Exactly. This is where the increasing use of living donor liver transplantation offers some hope. It can potentially improve access and decrease those long waiting times for some patients.
That's a potential solution. Any downsides to transplant besides the weight?
Well, a critical consideration is the immunosuppressive therapy. It's absolutely necessary to prevent the body from rejecting the transplanted liver. But those same drugs that suppress the immune system can potentially enhance the risk of metastasis or recurrence of any microscopic cancer cells that might have remained. So it's a very careful balancing act.
Absolutely fascinating, the options and the challenges. Now, beyond the surgical suite and all the medical treatments, the human element of care, particularly the nursing management and the ongoing support, is just absolutely vital. This really brings us back to you, the listener, and thinking about what comprehensive care truly looks like once a patient is perhaps out of the operating room or dealing with ongoing treatment.
Absolutely. For patients who are anticipating surgery for liver cancer, crucial psychological preparation, support, and education are provided beforehand. It's a major undertaking. Then, post-surgery, those first 2 or 3 days are critical. They involve intensive, very close monitoring for potential complications, cardiopulmonary issues, vascular problems, respiratory difficulties, liver dysfunction kicking in, metabolic abnormalities, and extensive blood loss can occur during these big surgeries. So that's watched closely too.
And people often go home still needing treatment.
That's a significant reality, yes. Patients are often discharged home while they're still receiving chemotherapy or maybe radiation therapy, and frequently they might have things like biliary drainage systems or hepatic artery catheters still in place.
So education becomes key.
Hugely important. And this is crucial for you as a learner to understand. Extensive patient and family education for self-care is absolutely paramount. This includes teaching them how to recognize and report potential complications and side effects of their chemotherapy, how to assess the infusion site, understanding the whole medication regimen.
What about those drains and catheters? That must be scary to manage at home.
It can be daunting.
Sure.
So, for those with biliary drainage systems, education needs to address that common fear of accidentally dislodging the catheter. We teach proper catheter care, keeping the site clean and dry, assessing it regularly for infection, and importantly, teaching the correct irrigation techniques, usually with sterile, normal saline or water, and emphasizing not to aspirate to avoid pulling stomach or duodenal contents back into the bile duct. Patients and caregivers must know exactly when to call their healthcare providers with concerns. We often use the teach-back method here, having them show us what they've learned to make sure the education is effective.
Makes sense. And implantable ports.
Similar thing. Education covers the chemotherapy regimen, the specific medications, potential side effects, and strategies to manage those side effects. For hepatic artery ports specifically, it also involves teaching them how to assess for signs of infection or inflammation around the port site between their infusion appointments.
It really highlights the importance of thoughtful, continuing and transitional care once they actually leave the hospital setting.
Exactly. The nurse's role in this phase is just vital, assisting patients and their families to cope not just with the physical symptoms, but also the emotional impact and the often poor prognosis associated with advanced liver cancer. This includes ensuring their physical and psychological well-being, making sure pain is adequately controlled, and maintaining their nutritional status as best as possible. Home visits by nurses are often essential to check on things like chemotherapy pump function or those drainage systems.
A real team effort then.
Absolutely. It's a truly collaborative effort among the entire healthcare team. Doctors, nurses, social workers, dietitians to manage those ongoing symptoms patients might face, like weakness, that persistent itching, inadequate dietary intake, jaundice. And importantly, it involves having sensitive, honest discussions about things like hospice care and clarifying end-of-life preferences, always ensuring the patient's wishes are respected and supported, providing comfort and dignity throughout their journey.
Today, we've taken a really deep dive into liver cancer. And I think we revealed some truly impactful takeaways. We talked about that surprising global prevalence of HCC versus its relative rarity in some regions, and that striking frequency with which the liver becomes a site for metastases from other cancers that really reshapes how you might think about liver cancer.
We also explored the intricate web of diagnostic tools and the really diverse and evolving range of treatment options, everything from major surgical resections and liver transplantation to highly targeted therapies and that vital, comprehensive supportive care.
It truly underscores the profound importance of, well, early detection whenever possible, the critical need to understand individual risk factors like those Hep B C infections or aflatoxin exposure we discussed, and the very multifaceted approach that's required for managing liver cancer effectively. It's really a testament to how far medical science has come, blending complex surgical interventions with novel therapies and that essential comprehensive patient support, always with an eye on improving quality of life for as long as possible. And this raises an important question as we wrap up. Consider how the ongoing advancements we're seeing in understanding the fundamental mechanisms of this disease, coupled with the rise of personalized medicine approaches tailored to individual tumors and various global health initiatives. How will all this continue to transform the landscape of liver cancer prevention and treatment? Could it offer significant new hope where perhaps it was once scarce? What further insights will future research reveal about the liver's truly remarkable resilience and about our ability to combat complex diseases like cancer within it?